Hello everyone, my name is Aida Matsui and I will be presenting the synthesis project presentation for a nurse-initiated triage protocol. So the overcrowding of the emergency room has been one of the major challenges our ER across the nation are experiencing. ER is the key access to the healthcare system when all other options are not available. Its main purpose is to provide emergency treatment and intervention, especially for higher acuity cases such as stroke, chest pain, abdominal pain, and all other injury. However, for patients who lack resources such as insurance or unable to get an appointment with their primary care, we tend to go to the ER to get immediate care. This added to the prolonged length of stay in the ER and overcrowding of the ER. So the nurse initiated triage standing orders or protocol has emerged as one of the strategies that can alleviate this overcrowding of the ER. It allows the nurses to begin diagnostic screenings by ordering labs and also providing intervention before being seen by providers. The significance of this evidence-based project is the focus on the implementation of the nurse-initiated triage protocol to ease the problem of overcrowding of the ER. It is aimed to reduce delay in care, to provide prompt intervention, and also to improve patient satisfaction. It does reduce ER wait times, it reduces the total ER length of stay, and it optimizes the role of the nurses in ER practice. For the pilot question, in patients presenting to the emergency department, how does the implementation of nurse-initiated standing orders during triage compared with standard triage without nurse-initiated orders affect the time to treatment, ER length of stay, and patient satisfaction during the emergency department visit? For search strategy and results, I uses the key terms as follows: nurse-initiated triage protocols, triage standing orders, emergency department triage, time to treatment, reduced length of stay. My inclusions are peer-reviewed studies, adult and pediatric patients, studies that are less than 5 years, and the setting for emergency room only. My exclusions are non-emergency setting, studies that are not evaluating nurse-initiated intervention, and articles without data or opinions. The database that I utilize are CINAHL, PubMed, Medline, and the Cochrane Library. For a synthesis of the literature, there are 4 key themes. First, the reduction of time to treatment. Multiple studies demonstrate that the nurse-initiated triage protocol significantly reduces time to medication administration or diagnostic testing such as EKG, labs, or imaging. The key findings shows that early initiation of care at triage improved clinical outcomes, especially in higher acuity cases such as stroke, chest pain, or sepsis. Second is the decreased length of stay in the ER. Evidence shows that reduced total emergency department length of stay improve patient outcomes or patient flow and decrease overcrowding. The protocol-driven care minimizes bottlenecks by initiating workups before provider evaluation. Third is improved patient satisfaction. Perception of faster care, increased confidence in the healthcare team, And also, meaning early engagement and symptom management can improve patient experience or satisfaction. And last is the safety and quality outcomes. There are no increase in adverse reaction if protocol are evidence-based. And second is the improved compliance with clinical guidelines such as sepsis bundles, chest pain protocol, or stroke protocol. The nurse-initiated protocols are safe when supported by training and, of course, clear guidelines. So the Iowa model is a well-suited framework for the implementation of evidence-based practice. The Iowa model collaboratively critically assess and synthesize information and recommendations before revising the model. It is systematic, practical, team-oriented framework for translating evidence into practice. In this model, there are 7 concepts, which is identify the trigger, formulate the question or the purpose, form the team, assemble and appraise and synthesize, design and pilot the project, identify and sustain key metrics, integrate and sustain practice change. For evaluation plan and measures, the formative evaluation plays a critical role in ensuring the successful implementation of the nurse-initiated triage protocol in the ER. Because this intervention directly impacts the triage workflow and also the nurse's autonomy and the patient outcomes, it is essential that we evaluate the process continuously rather than waiting for the final outcomes. The process metrics such as time from triage to order initiation and also the compliance rates will be monitored regularly to ensure to evaluate whether the intervention is being implemented as intended. For formative evaluation, is staff compliance with protocols, if there are barriers encountered, and of course ongoing feedback from nurses and providers. For summative eval, it's time to treatment, which is from check-in to the total of ED length of stay or disposition time, and last is the patient satisfaction score. For data collection and analysis, data are collected from electronic health records with information such as time of arrival, triage, order entry, intervention, and time of disposition. For statistical analysis, the pair t-test from pre and post implementation. The t-test is a method used to test whether the mean difference between pairs of measurements is 0 or not. For the dissemination plan, the results will be shared to stakeholders such as the ER staff, hospital leaders, and quality improvement team. It will also be discussed during staff meetings, huddles, QI boards, or leadership briefings. It may also be included in those professional conferences and also peer-reviewed publications, and later on can be put into posters. The timeline is from 0 to 3 months, which is going to be the internal dissemination and staff education. Within 3 to 6 months, it may be added to conferences and QI presentations, and in 6 to 12 months for publications. In conclusion, the nurse-initiated triage protocols represent a higher impact evidence-based approach to address emergency room inefficiencies. So the literature strongly supports that the practice change in improving delays in the ER, support nurses' role advancement. It maintains patient safety and importantly improve patient outcomes and satisfaction. Successful implementation warrants interdisciplinary collaboration, leadership support, and ongoing evaluation to improve the emergency room process. And these are the references that I use in this presentation. Thank you very much, and thank you for watching my presentation.